today we're going to start with the threats to self-expression. So that's going to be your hospice, home health, palliative care, end of life. We're going to start with home health care. These are your objectives. I basically have taken each objective, made a slide, and then talk about the objectives. What did I tell you guys yesterday about the objectives? It's all we can test off of, right? So if there's not an objective for it, we're not testing off of it. So basically I took the objectives. Here's what you need to know for that objective, right? So it's pretty much exactly what you need to know. Not necessarily to the test, but as far as like the NCLEX test plan tells us you need to know. So we're going to start off with the governmental services available. Again, you guys have these to be able to actually click and go to if you want to. I'm going to click real quick over here into the bring up for you Part A. So this is Medicare Part A. So who gets Medicare?
65 years old.
65 and older, right?
Or unless they got a disability.
Then they're on Medicaid. So Medicare is 65 and older. So Part A covers all your hospital inpatient care, your skilled nursing, your inpatient care in a skilled nursing facility that it's not a long-term care. Now, I don't know if you guys know this, but there's actual long-term care insurance that people can buy, and there are people who have bought this way back when, and they're living in these super fancy ALFs now, and they're not really paying much for them. ALFs are expensive. They're like $5,400 a month. Crazy. So there is long-term insurance, but this is not covered in here. That would have to be something completely separate that they've purchased on their own, and a lot of places don't even offer it anymore. Part A covers hospice care, but when we get to hospice, you'll learn that hospice doesn't turn you away. Like, we see people under the bridge on 54th Avenue South. That's their address. That's where we see them. If you don't have money to pay, we're not going to do it. Doesn't matter. We take everybody. But they can get money from the Medicare Part A if that person has Medicare Part A. And then it covers home health care. And then Part B is all your medically necessary services. So ambulance services, your DME. So what's DME? Like so your walkers, your hospital bed if you're going home, with a skilled nurse, or if you're going home with home health care after a knee replacement, right? Walker, toilet riser, shower chair, yeah, all that stuff. It covers mental health inpatient and outpatient services. And then it says limited outpatient prescription drugs, but that's what Part D is. Part D is for drugs. And you guys don't need to memorize what's what. Just know, though, like going into see your patients and going into the NCLEX, that there are different parts that cover different things. Switch back over. And then there's yeah?
Can you get all of them at once?
Yeah.
Oh, okay.
So most people have Part A and B, and then I think you have to pay for Part D possibly, or you get a portion of Part D, but then there's optional things that you can add on to. I know, like, my grandfather just passed away last semester, so I was deep in his everything as far as, like, when we went to the hospital with all of his cards. And I know that he had, like, his Medicare card, but then from his prior employee, he also had AARP or something that had an additional drug benefit on it that would pay for any medications that Medicare wouldn't. So, but I know that they can actually purchase, like, there's other Medicare Part F. I don't know what that is. You don't need to know that, but there are other parts to it. So, and then what's Medicaid? We already said it. So it's somebody who has a disability, right? Is getting some sort of like Social Security disability, and so, or somebody who lives under the poverty level, they can get the health insurance through the state. That would be like the Medicaid. And there's different things with that too. Here in Florida, they have like a special kids one. They have one special for pregnant moms. So that's the Medicaid. So the Medicaid is like disability, poverty line. Medicare is 65 and older.
So I thought Medicaid too said that it was covered under 65 if your disability or end stage renal disease.
Right, so it won't stop. They'll still continue. You can have Medicaid and Medicare.
Oh, okay.
Okay?
So, okay.
So we're going to talk about the factors influencing change in the healthcare system. So basically meaning that we've shifted from hospital-based care to a lot more home health care, right? So it used to be that Grandpa went to the hospital with pneumonia. He was in the hospital for 3 weeks. They kept him until he was like jogging on the treadmill with PT, right? Because the hospital wanted to get paid. So they're just going to keep him as long as they can, and they're going to milk it. So now we have these things called DRGs that basically say, okay, so you're here for CHF. So we've determined throughout the years from all the patients that we've seen with CHF that your care should cost no more than $5,700. I'm sure that's not what it is, but that's how much it should cost from the time you step foot into the hospital to the time you discharge. So that's what we're paying you for this patient that comes in with a diagnosis of CHF. So do you think the hospital is going to keep them there until they're running on that treadmill as healthy as can be? No, they're going to say 3 days later, oh good, everything's kind of stable, you can go home, or you can go to a sniff. So that's why now when you go in, and I don't know if anybody has, this might keep timing out on me too because I'm not touching it, but if you go to the hospital now and you have Medicare or you're with someone who has Medicare, somebody comes around and she has you sign this paper that basically says if you feel like the hospital is discharging you sooner than you feel necessary, that you feel like they're pushing you out before you're ready, you call this number. So, so basically, the hospitals have to play this game of, are they well enough that we're going to send them home and they're not going to come back? Because if they come back in the next, 30 days with the same diagnosis because we didn't get them well enough, we're not going to get paid again. So what they do a lot now is instead of just, the last couple slides didn't record. I'm going to have to keep hitting record every time it times out or not let it time out. Complicated wounds and dressing. So if I have a patient that goes home and they're wheelchair bound and they have a huge sacral wound, do you think they're going to be able to take care of that wound by themselves? Maybe they're a double amputee. No. It's going to be really hard for them to dress their own wound, right? So that would require home health care. Medication monitoring. Sometimes the patient is new warfarin, so they leave the hospital on Coumadin, and so for the first couple of weeks, we have a nurse go in and they do the little finger prick INRs, and we'll keep track of their INRs every couple of days just to make sure that the levels stay where they are, and make sure we're doing training with the patient. If it's going up and down, we're talking to them about the foods that they're eating and drinking, because that'll affect it. So home health care services, covered by insurance. The doctor there has to be a doctor overseeing it all, right? They have to be signing the orders for home health care and any orders that we need done. So when I worked for the orthopedic surgeon, I was his nurse practitioner, so basically I vetted all the calls and everything that came through. So the RN, who is kind of like the team leader, would call me and say, hey, we're going to do this, 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 and this. Is that okay? Yep, sure. So they would just call to make sure that was a verbal order. So there has to be someone signing the orders. They just can't just decide what they're going to do. It has to be a licensed agency. So I can't just decide, hey, I'm really good at taking care of people. I'm going to start my own home health service over here, right? I have to go out, I have to do the right steps, I have to get licensed. To qualify for home health care, now we're going to do the air quotes for homebound status. Does that mean your patient can't leave the house ever? No. They can still go to their doctor's appointments, and they can probably have, my next door neighbor take me to the grocery store, but I'm not out running around shopping at the mall, going to CD Roma's for dinner,
They do have Lucky's at the mall.
They do have Lucky's at the mall. And the patients have to need, like I said, that skilled RN care. So like I said, the RN is kind of like the apex up here. She's the the coordinator of all the care. So is it just nurses that go into patients' home for home health care? No. Everybody goes in there, right? We can get speech therapy, PT, OT, spiritual services, you name it, we can get them in there. So the responsibility of that RN, though, is to kind of assess the patient and then determine what services are needed, call the physician, get the orders, and then get the other services in. They're kind of accountable for the supervision of all those people, making sure that they're actually getting in. So the RN doesn't necessarily do a lot of hands-on after that first assessment. They're more like that coordinator, like the caseworker when it comes to home health care. They want to make sure that everybody's getting in there, everybody's doing what they need, the patients are getting the teaching that they need, that if they do have that new ostomy, that they're getting the care to it. So what should the home health RN incorporate into the care plan for each patient?
What skills are necessary?
What skills are necessary?
What the patient needs to be, or is holistic status.
What the priorities are? What about the documentation to continue? So can I just write every time I go in to see that patient, WNL will continue to monitor, right? Within normal limits, we'll continue to monitor. No, because what do we need to show so that the insurance will keep paying for us to go in there?
That is a need for you.
That there's a need. So we need to document, if there's a decline in anything, if the patient's actually doing better. Because I'll tell you that if they see that the patient's just sitting here like this and we're never saying that anything is getting better, they're going to say, are you even doing your job? Like, what are you there for, right? So we have to make sure that we do good documentation to support the continued need for home health care, that they still need that RN skilled nursing service. During a home health visit, you note several bruises on an elderly patient. What should you do?
Look at them, try to ask questions.
Find out what happened.
See what
They might have
medication.
fallen.
Right, find out what happened, ask them, they might have just fallen. So, what kind of medications are on? You should know that, though, as the RN visiting them.
Or look up their marriage.
So, is it your job to call DCF or whatever it's called down here?
The abuse hotline.
If you think it is.
You
if
can
have
call the abuse
evidence.
hotline, but you have to do whatever your employer,
Agency.
whatever their procedure is, their policy.
You don't have to get you a high chair, you ain't gonna be able to move.
Mm-hmm. And I end up sitting up here all by my lonesome. And then we talked about the prospective payment, right? How it impacts home health services. How do you think that impacts home health services? It's going to be the same thing as the hospital, right?
That's how they get coded.
The insurance is going to say, oh, they sent this person home and they have that CHF. Well, now we've determined that this person should only cost you this much. So it's going to be the same thing. So that is home health care in a nutshell. Do you guys have any questions about home health care?
So is that,
Yeah.
determined, payment is fixed?
A lot of times it is fixed. It goes by the insurance company. It's the DRGs. So if you just Google like DRG, it'll come up and tell you this whole thing. And you can actually probably pull up exactly what they'll pay for each disease. So that's kind of really put a damper on patients staying in the hospital as long as they should. Don't get me wrong, there are patients there that are there way longer than they should be, but it's usually your uninsured patients or self-pay, or your uninsured patients that need to go to a skilled nursing facility, but no one wants to take them because they don't have insurance. So insurance really, like, you don't just go to the hospital and not think about it and get better anymore, right? Everything is mandated through the insurance company as to what you can and can't do and how long you can do it for. And if it doesn't work, this is going to be your next step.
You have to even say what you need. As a patient, you have to say the right thing in order to even get seen sometimes.
Yeah.
I have a question.
Yep.
So my question is this, you said that for you to be qualified for home health care, you require a skills set of an RN.
Yep.
So an RN needs to be the one that will assess you, but you also said that, I just want to clarify.
No, that's okay.
So you also said that even though there's an RN there, they are not the one that actually do the hands-on care.
They'll come in the first couple of visits. The RN will be there, and they'll be the ones because they need to do that initial assessment. What else are they going to do on that first visit besides just assessing you?
Your caregiver, knowing if they
Yeah,
need
they'll
teaching.
assess anybody who lives with you and see what kind of teaching they need, or if they're maybe there are bruises all over you, and there's this really weird nephew who won't leave the room ever and doesn't talks for the patient.
Or even they're competent to even help you out, or if they're
Yeah.
able to.
What else?
So if
What else are they looking at though?
The environment.
The environment. So what's a huge issue with the elderly?
Falls. Kind of like where they're living.
Air conditioning.
Drugs.
Air conditioning.
Shower.
Towel
The
rags.
elderly in the state of Florida, that's why it's being mandated for all the ALS and the SNFs now. The air conditioning, generators and all that.
He talking about the hurricane.
Oh. So falls are a huge issue. What do you think of the two top causes for the falls?
Shower.
No.
The rugs on the floor.
Fall or it's area rugs and what?
Electrical cords.
Small pets. Seriously, they get under your feet and you're walking around and you're tripping over them. Yes, so they need to go in and they have to assess all of this and see what they need to do. I did an entire month clerkship out in Martha's Vineyard when I was in graduate school in falls for the elderlies, and the area rugs were the hugest thing out there. They were almost the cause of every fall. Yep.
I have a question about, so if somebody has multiple conditions, how do they calculate it?
I have no idea. I'm sure that there is some calculator somewhere that someone's sitting at. I honestly don't know. Just know though that the insurance kind of regulates everything now, is right down to how long you can stay in the hospital that they're going to pay for. So now we're going to go into palliative and hospice care. Let me show you my little hospice. I love this video because I think she's the cutest thing ever. Oh, I think there's supposed to be sound. Alright, well, maybe not. I'll fix it. We'll watch it later. She's so cute, though. Okay, so these are your objectives for hospice and palliative care. Describe the meaning of the different types of advanced directives. That should say advanced, not advanced. Differentiate between palliative care and end-of-life and hospice care. Discuss the unique characteristics of end-of-life and hospice care for the dying and their significant others. Identify criteria for admission to hospice. Describe the scopes and services available through hospice. The barriers to getting hospice. And then summarize the physical and psychosocial manifestations of approaching death. Also, the importance of client culture and ethnicity when planning and providing and evaluating care, the ways that we can assist in managing physical symptoms, the spiritual needs of the dying patient, the stages of grief, and then the ways we can help the family. So when we talk about advanced directives, we have the healthcare surrogate, which is what? What's a healthcare surrogate?
That's a person that can speak for you.
Person that can speak for you if you can't speak for yourself. Is that someone I pick or that someone else picks?
Someone that you pick as a patient.
I pick them, right? So in the state of Florida, you'll hear healthcare proxy also. So a proxy is someone assigned to that patient. So let's say,
Social services or something.
yeah, so let's say like the person doesn't have a healthcare surrogate. They're maybe a homeless person or someone who just doesn't have anybody, or the family can't agree. So then they'll,
Is that our alarm?
yes,
I think we gonna get killed if we can't even hear it enough.
yeah, that's
If we were rowdy, we just